We are live.
Good morning, everyone. Welcome to International Weekly Meeting. We are on we are on 63rd session, and total accumulated session is 2696. A journey started about a year ago by Dr. K.K. Agarwal. Today we have Dr. Veena Agarwal with us to introduce the topic and the speaker, who is Managing Director for IGCP Group, also the trustee for Heart Care Foundation of India, and she's also the wife of Dr. K.K. Agarwal. Over to you, Dr. Veena Agarwal.
Good morning and a very warm welcome to each one of you for today's session. I'm as surprised to be here as probably you all are to see me. But as Dr. K.K. said, the show must go on, and we all have to carry his legacy forward. Thank you for helping us do that. Our topic for today is reinfection in SARS-CoV-2. Since the beginning of COVID-19 pandemic, the possibility of potential reinfection has always been a threat. Today, we know that reinfection does occur, but it is difficult to assess the actual risk of reinfection, as many people with mild symptoms may not have undergone an RT-PCR test. There's also a requirement of fulfilling specific criteria of reinfection for the purpose of reporting such cases. So why do we need to talk about reinfection? Because it not only helps in deciding the intervention strategies required to control the spread of the disease, but also helps to assess for how long people have to follow COVID-appropriate behavior like masking and social distancing. ICMR defines reinfection as any individual who tested positive for coronavirus on 2 separate occasions by either molecular tests or rapid antigen test at an interval of at least 102 days, with 1 negative molecular test in between. But a confirmation will require a genome testing, which is not accessible to the common man. It has been reported that people who have COVID-19 are highly unlikely to contract it again for at least 6 months after their first infection. The reported prevalence has so far shown that reinfection is rare but possible. An ICMR study has shown the prevalence of reinfection in unvaccinated individuals as 4.5%. Another study among healthcare workers cited an incidence of only 1.6%. To throw more light on this extremely important but ill-understood topic, we have with us today Dr. Jayanti Shastri, Professor and Head, Department of Microbiology, TN Medical College and Nair Hospital, Lab Director, Molecular Diagnostic Reference Laboratory, Kasturba Hospital for Infectious Diseases in Mumbai. Her lab was one of the first 13 labs in the country identified by ICMR to conduct RT-PCR. She has been spearheading COVID-19 diagnostics in Mumbai and is conducting quality assurance for 35 labs doing RT-PCR in Mumbai, and the lab serves as a validation center for antigen kits. She has published her work on reinfection of SARS-CoV-2 in Frontiers in Medicine, and the team's work in immunology is published in Frontiers in Immunology. Today, she'll be talking of the classic definition of reinfections, breakthrough infections and escape infections, and presenting a very interesting case that defies established definition for all the 3 types of entities. Welcome, Dr. Shastri, to our August platform. We will have your presentation followed by a discussion and Q&A. Over to you, Dr. Jayanti.
Thank you so much, Dr. Veena, for your kind introduction, and good morning to all of you. It's indeed my privilege. I had the opportunity of being on this platform with Dr. KK, and our memories go down many years with Dr. Veena and Dr. KK, and indeed we miss him so much because these lectures used to be just a part and parcel of all of us, and we used to keep sharing our experiences. And this is a very good platform for me to share our experience in SARS-CoV-2 reinfections. And friends, I would like to also share that vaccination, yes, is definitely required. But after the presentation, we will have a discussion about the role of vaccination and how much is the reassurance. Can I please share my screen?
Yes, ma'am, you're allowed.
Yeah. So Today's topic is on SARS-CoV-2 reinfections. So as Dr. Veena rightly said, it's extremely difficult to establish reinfection. We do have a lot of...
Would you be able to do it on a, would you be able to do it on a presentation mode so that we can also...
I did. Is it not a full screen?
No, you just have to...
Okay. Yeah, sure.
Perfect.
So the challenges in proving reinfection. All of us do RT-PCR tests for diagnosis. Now that is not enough to prove reinfection. There have been a number of anecdotal cases of reinfection. But the most important thing about establishing reinfection is molecular detection of the virus at two different time points, that is 2 different episodes. And there has to be an intervening negative test, as well as genetic sequencing data has to be there in order to prove reinfection. Now, the first challenge which we have is in banking of samples. Now, my lab is a public health reference lab, and that is why we bank samples, whereas private labs are not mandatorily expected to bank samples as per ICMR. The ICMR is the Indian Council of Medical Research, which overlooks the diagnosis in the country. They are not, it is not mandatory for them to store the samples. So beyond 1 month, it is very difficult to get the samples. So that is the first challenge which we face in establishing reinfection. So that is the reason it is very easy to say that, there aren't any cases of reinfection, because it is very difficult to prove it. But anecdotally, if you ask people, they will say, yes, X had a second episode, Y had a second episode, however, not proven. Now, limited availability of routine sequencing capabilities. How often can we access research labs for sequencing? It's again a challenge. So these challenges explain as to why very few cases have been described to date. Now, as per the CDC definition, you have to investigate a case. Most importantly, the duration has to be more than 90 days and a cycle threshold value of less than 33 days. And there has to be symptoms of COVID on both the episodes, or duration since previous positive test as 45 to 89 days and a cycle threshold value of less than 33. This is again a challenge. It's a caveat. Less than 33. The reason being, it's very difficult to sequence any sample which has a CT value of more than 33. So this is something which we face as a clinical microbiologist. I face a lot of problem explaining to the clinician why it is difficult to sequence a sample whose CT value. So as per ICMR, anything beyond 35 is to be given as negative. So 33, 34, 35. These are the 3 CT values, which is again a challenge. There has to be a negative test between 2 episodes, and the duration is either 90 days or 45 to 89 days. And if you have that, then you start investigating this. And when you investigate and you send it for genome sequencing, you have to show different clades between the first and the second episode infection. So that will prove reinfection, or you have to show more than 2 nucleotide differences between 2 episodes, because what is expected out of the virus is about 2 nucleotide differences every month. So this is a very important caveat in the investigative category, is the immunocompromised individuals who have an extended period of viral shedding. So how do you factor immunocompromised individuals in reinfection? This is something which we need to really discuss and come up with guidelines. So the best evidence is, of course, differing clades. Moderate evidence is 2 nucleotide differences per month is accepted, so anything more than 2. And poor evidence is if there is less than 2 nucleotide differences per month. So this is as per CDC guidelines. which was CDC, the US guidelines. The EU guidelines, which came up very early in July 2020, were not very confirmatory. So we followed the US CDC guidelines for establishing reinfection. In the meanwhile, the ICMR came up with this paper in epidemiology and infection. They did a telephonic survey because, as I told you, it is very difficult to establish reinfection without genomic surveillance. So they came up with an epidemiological case definition of reinfection. The gap should be 102 days, and there should be a negative PCR in between 2 episodes. With this telephonic survey, they established a 4.5% of SARS-CoV-2 infected individuals in India have had reinfection. Now, this is, mind you, by a telephonic survey, and they have taken 102 days. Now, this seems to be a little arbitrary in the light of the case, which I would be presenting very soon. This is a systematic review, which is published in the Journal of Clinical Microbiology, describing 16 cases in the world. The first, of course, was Toe et al., then Nevada case of Tillet, and our case series has also been mentioned and discussed in this systematic review. This is published in April 2021. They have selectively taken 16 cases where there have been different clades or more than 2 nucleotides between 2 reinfection cases, but at an interval of either 90 days or 45 days if the clades are different. So the definitions have been established very clearly. So this was our work on clinical, serological, and whole genome sequence analysis to confirm SARS-CoV-2 reinfection in 4 patients from Mumbai. This is published in the Frontiers in Medicine. So what we really saw in this was reinfection in 5 patients to start with, we suspected. There were differing clinical symptoms, and the second episode, the symptoms were much more. They required hospitalization, and there was increased severity. In some cases, after the first episode, antibodies were present. Neutralizing antibodies were also present. Now, in the context of SARS-CoV-2, there are 2 types of antibodies we look for post-infection. That is the presence of nucleocapsid and S1-RBD, the receptor binding domain antibodies, which are the binding antibodies, and the other one is the neutralizing antibodies. The neutralizing antibody test is on a research use test, which is not available to the diagnostic labs. So we are doing it in our reference laboratory. And we could do whole genome analysis because we had banked the samples, and therefore after 90 days from our freezers, we could pull it out and send it for whole genome sequencing. And through sequence analysis, clinical presentation, and seroconversion, we could establish reinfection. So this is our lab where we do the RT-PCR test. We have a BSL-2 plus lab with all the equipments required for RT-PCR, and now we are setting up a genome sequencing lab. And we have been regularly doing almost about 500 to 700 samples per day, which extends up to 1,000. Now, coming back to our case. So what we saw in patient A and B, in one we could not prove. In A and B, we saw a difference of more than 2 nucleotides, but there was not a clade difference. Whereas in patient D, so C we had to drop because the gap was only 19 days and we could not establish 2 different clades. Now D, we had 2 different clades, and E, we had 2 different clades in the phylogenetic tree. So this is prepared with reference to the Wuhan strain, and we plot our own genome sequences and make a phylogenetic tree to establish reinfection. So in patient A and patient B, D, E, we were able to establish on the basis of the non-synonymous mutations which were seen between the first sample and the second sample. And we did some protein annotations also, and we could find between the first and the second sample, there were a lot of differences. And you could see that as early as 2020, we could even see a lot of D614G mutation in the spike protein in the protein annotations. So we assigned reinfection on the basis of the CDC criteria in 4 patients. Patient A had weak evidence. Patient B did have a D614G, which was absent in the second episode, and that is the reason it was assigned as a case of reinfection. Whereas D and E had very strong evidence. They had severe presentation in the second episode. CT value was less than 33, and there was a clade difference, and there was specific mutations which was present in the second case. Now, this is what we knew till vaccination was introduced. As we all know, that vaccination was introduced in India on 16th of January by the Prime Minister of India. At that time, we thought that we have won the war. Now, just by giving the vaccine, the antibodies will be produced, and we will be saved from this wrath of getting reinfected in patients who have already had the infection. And in those who were not infected, it was really that magic bullet. Now, here I'm going to discuss a case of breakthrough reinfection. We call it breakthrough because this was in a vaccinated individual, and we call it reinfection because it involved 2 episodes with 2 different clades of the virus. Now, this terminology, we'll be actually publishing this as a preprint and then as a case record, because this terminology, breakthrough reinfection, is something which is very new, and we would like to introduce this to the scientific community. So what is a breakthrough infection? Is a vaccine breakthrough infection is defined as a detection of SARS-CoV-2 RNA or antigen in a respiratory specimen collected from a person more than or equal to 14 days after they have completed all recommended doses of a COVID-19 vaccine. In India, we are giving the Covishield or the Covaxin, and therefore infections occurring at least 14 days after the second dose qualify to be called as a breakthrough infection. INSACOG is the consortium which is doing regular genomic sequencing in the country. Currently, there are about 17 centers in the country doing regular genomic sequencing, and they have found that the Delta variant has been overrepresented in breakthrough infections. Most of the breakthrough infections are by the Delta variant. And the variants of concern appear to confer high risk of breakthrough infection. So this is a case we would like to present of a 61-year-old female doctor who had totally 3 infections, 2 breakthrough infections and 2 reinfections. She had a past medical history of bronchial asthma, hypertension, pre-diabetes, had an asymptomatic SARS-CoV-2 infection in August 2020. Now again, an asymptomatic SARS-CoV-2 infection does not mount an adequate immune response to produce adequate quantities of neutralizing antibodies, which has been proven beyond doubt last year. It's only the symptomatic who mount an adequate immune response. She had taken Covishield on 1st February, and the second dose was taken on 15th of March. Seroconversion was documented after vaccination by the production of binding antibodies, that is anti-RBD IgG by the Abbott test. On April 10th, she developed symptoms, which was the first breakthrough infection and first reinfection. Why do we call it reinfection? Because she was already infected in August 2020. PCR was positive, and when her sample was sent for whole genome sequencing, the report was of an alpha variant. Subsequently, she had a negative test And then April 25th, again, there was a symptom onset with second breakthrough infection, which was a second reinfection, because in addition to breakthrough, it was by a different, it was a variant of concern. It was a Delta variant, which was detected by the whole genome sequencing. So the first breakthrough was on April 10th. She presented with abdominal fever, pain, fever, fatigue, myalgia. PCR was positive on April 12th, and that sample, by whole genome sequencing, we could detect the alpha variant. She had very mild symptoms. There was home isolation and treatment at home. There wasn't any breathlessness or hypoxia. CRP was elevated. However, it became normal by the 21st. HRCT chest was done and the score was about 2/25. April 21st, all the symptoms resolved completely and she was PCR negative. So this is very important when you talk of reinfection, that there was a negative PCR test. And the second breakthrough, symptoms had completely resolved after the first episode. Patient was asymptomatic for 4 days. The PCR was negative on 2 consecutive tests, that is on 14th and 21st. CRP had reduced to normal. Radiological changes had resolved. Here, a close contact with a family member infected also with the Delta variant was there. There was a close contact. And patient had received 10 days of oral steroids, which may have delayed the response. Symptoms developed on 25th of April, which we describe here as the second breakthrough and the second reinfection. Initially, there was fatigue, myalgia, cough, later fever, chills, breathlessness. PCR was positive on the 3rd of May, and whole genome sequencing report was of the Delta variant. Serial positive PCRs with decreasing CT value, which means that the viral load was increasing. She had breathlessness, developed hypoxia, required hospitalization and supplemental oxygen. CRP, IL-6, D-dimer, all was increased with clinical progression. HRCT was initially 7/25, which became 12/25 with clinical progression. But all the while, serology was positive with the boosting of anti-RBD IgG. Now, here is a cause of concern. So, presence of binding antibodies, does it confer protection? We are very well aware of the variants of concern. As per the WHO, it has been alpha, beta, gamma, delta. We had an outbreak of alpha variant in Mumbai in the months of February and March in the community itself. We had a second wave due to the delta variant. And now this is a cause of concern when it comes to vaccines. Now, we know across the globe, there are different kinds of vaccines which have been given, instituted, and they have different efficacies. Here are the questions. So variants of interest also, we know they have yet not been labeled with severe infections or with transmissibility, and that is why it remains as a variant of interest. But however, there is a scope that a single mutation in these viruses can wreak havoc. So we are in fact sitting on a time bomb, waiting for it to explode. Are we going to get the third wave or not? If yes, which is the virus which is of concern? So here is what I thought would be the discussion points. Reinfections do occur. Occasionally, they may be severe. If you see the world literature, they talk about 2 infections in which the second infection was not severe, but we have documented as early as August 2020 that in healthcare workers, we did see severe infection, which has been published. Breakthrough infections are occurring. We are seeing a lot of breakthrough infections even in Mumbai, and most of them are with the variants of concern. So the question whether the vaccines which are instituted in the country are adequate enough to produce antibodies which are going to confer protection. Here we have documented 2 breakthrough infections, and both have been reinfections in an individual who already had an asymptomatic infection last year. So these appear to be very rare and difficult to establish, but occasionally can lead to severe disease and hospitalization. Here we could prove reinfection because we did a whole genome sequencing. There is an urgent need to ramp up sequencing facilities in the country to prove breakthrough and reinfections. Why do you have to prove breakthrough? Because we need to know which is the variant of concern which is involved in breakthrough, and if we need to establish reinfection, we need to do whole genome sequencing to see whether the variants of concern were different. Do not disregard COVID-19-like symptoms in convalescent or vaccinated individuals. So the question is, can also steroids predispose to reinfection? This is just something which I thought we should ponder about. If you see the world literature, the Danish study very clearly says it has followed up almost about 16,000 healthcare workers, and Danes are very good in record keeping. So they have seen that the reinfection is to the tune of 1%. This is just a follow-up study of the healthcare workers, and it's an epidemiological study where they have shown 1%. The other thing which is a cause of concern is the viral shedding. In immunocompromised patients where the period of shedding is prolonged, there is a scope for variation of the virus in vivo. When you have a variation in the virus in vivo, again, there is always a reason to believe that there can be reinfection, because the virus may not be at detectable levels in the respiratory specimens. However, it may be somewhere, it may be sequestered in the body. So these are the things I thought were the points to discuss in this forum. And of course, there is no way that we can do away with masks or hand hygiene, and crowding is an absolute no. Social distancing is very important. And it's really not time to say goodbye to masks. And again, the cause of concern is there is a no masking policy in the US, and we have so many students across the globe going to US for studies around August. Now, what's going to happen? Are they going to revaccinate them? Are they going to give them the Pfizer vaccine and boost their immunity? Or they are left to chance because they have been immunized with either Covaxin or Covishield? I'm really concerned about the students who are leaving my country and going to the US for studies. So with this, I end my presentation, and I have my heartfelt gratitude for all my staff who've been tirelessly working right from the start of the pandemic in February 2020. Thank you very much, and I would be very happy to take questions and participate in the discussions.
Thank you, Dr. Jayanti. Before we open the question answers, I would like to acknowledge the presence of various associations. Dr. Jong from Singapore Medical Association is a chair for CMAAO. Dr. Ravi from Malaysia Medical Association, he's the immediate past president of CMAAO. Professor Ashraf, first president of CMAAO, and from Pakistan. Dr. Salma, president Pakistan Medical Association. Dr. Jamal Chaudhry from Bangladesh Medical Association. Dr. Asaf Hussain from South Africa Medical Association. Dr. Sajad from Pakistan Medical Association. Dr. Shashank Joshi, from endocrinologist from India. Dr. Monica Vasudev from United States. Dr. Sanchita from IGCP Group. Dr. Meenakshi from Heart Care Foundation of India. And I would like to welcome Dr. Chong as a chair to chair this meeting. And we would like to open up the question answers.
Thank you, sir.
I also would like to acknowledge Dr. Hussain, who just joined in. Sorry. Yeah.
Thank you, everyone, for joining our Saturday session. As always, it's a great presentation by Dr. Jayanti. Actually, before I open the floor to some questions, I myself have some interesting questions to ask her. So, Dr. Jayanti, for this genome sequencing, is there a CT value that you need to be below before you can sequence the genome? I understand that it's something like that. Is that right?
So currently the consortium is able to sequence, see, there are various sequencing platforms across India they are using. Some of them are using the nanopore sequencing, and some of them are using the Illumina sequencing. So when it comes to Illumina sequencing, CT value of say around 30, 32 should be fine. But if platforms are using, I mean, some institutes are using the nanopore sequencing, then they accept samples only up to a CT value of 25, which is a big challenge because what happens to those samples which are between 25 to 32 or 33? So you're not able to establish reinfection in these cases. So the point which I actually would really like to re-emphasize is reinfections are happening. They are not getting documented for this big caveat that we need to establish 2 different strains of the virus.
Yes. Dr. Jayanti, I understand the criteria has to be fixed for reinfection. Otherwise, we'll be, we won't be comparing apples and oranges. Can I ask also a question? Do you think that these reinfections are linked to a high viral load? That means, for example, if you're in an epicenter where there's a huge viral load all around you, and even though you're vaccinated and so on, do you think that this high viral load has a role to play in reinfections?
More than the high viral load, the case which I had presented very clearly says that we need to redefine reinfection, because the case I presented had a reinfection in 19 days. So,
Yes.
which is not yet been shown in literature, and we are going to write it up as a case report, asking the scientific community to relook into the definition. More than the viral load, it is the variant of concern, which is, very important in a breakthrough reinfection. So as we had shown that in this case, the first variant was the alpha variant, and in 19 days, it was the delta variant. So more than the viral load, see, these viral loads and all have become a story of 2020. In 2021, things have really changed with reference to the variant of concern. So that is our immediate thing which we want to highlight.
I see. Thank you. Thank you very much. Yes, Dr. Yes.
Can I add something?
Yes, Dr. Bukhari? Yes.
Yes, Professor Bukhari speaking. Unfortunately, due to problem, I could not join the full lecture. Sir, the viral load. In my own practice in Pakistan, there are 3 parameters, 3 different things after reinfection. I also gave the lecture of the reinfection, chances of reinfection 2 days earlier. Number 1, you are right. The 3 important causes in Pakistan. One is the immune system is dysregulation. Your immune system is dysregulated at such a level that even the PCR is negative, but your immune system is still in the state of renewal. This is the one major cause of the reinfection. And the second was cause, as the madam was telling, that the variant of concern, which is escaping our immune system, which is evading our like B61 delta and A and B. And the third important thing is that if you are getting direct infection from the patient where the viral are already replicating, sometimes get a virus is present on the surfaces, which is on the air. This virus is not lethal compared to when you get the virus directly from the patient. Yes, from the patient, which is in a state of replication, and it is a high viral load. High viral load is an important infection which has been looked. There are three important studies in the CDC, and they have endorsed these three things, that if the patient is immune system is right, that practically, and one more definition of reinfection. The definition of reinfection, we have published our own data, and the USA has redefined the reinfection. Number one, there are three major criteria and three minor criteria. Three major criteria is the positivity of PCR, number two, the CRP, number three, PCR. Yes, some people do not go for the PCR. Their symptoms are okay. They say, no, we are now okay. We, as a doctor, as a student, it is not the reinfection. It is a continuing infection which they are not clearing, because sometimes their infection is prolonged. This virus is not only present in our nasopharyngeal here, they escape in the intestine and the joints. So this is very important to clear the definition. If your parameters are clean, then if once the patient is negative from this major criteria, minor criteria, and then get the infection, we will define it either into 90 days or even to 6 months. So this the time period is not important. Importance of the negativity, reinfection, the once the patient has 6 parameters completely negative and then get the infection. Thank you so much, sir.
Thank you, Dr. Bukhari. Was difficult listening to you. Your feed was a little bit tough, but I'd like to just summarize and say that it's the three things that we are concerned about was direct,
once again, sir.
Direct viral load from the patient, highly infectious viral load from the patient, and then of course the host factors, right? Whether your immune system is dysfunctional or dysregulated. And then finally is, of course, the variant. So these are the three important driving factors for reinfection. Am I right, Dr. Bukhari?
Yeah, I would also like to add a couple of things because, and again, Shashank has asked some questions which I would like to answer. So Shashank is a very good friend and a colleague from Mumbai. So I have the liberty to call him Shashank and not Dr. Shashank. So Shashank, 35 is ICMR's limit for RT-PCR. It is not for sequencing. In fact, the consortium is asking for samples of 25 and below 25 for genome sequencing. Now, the caveat again is a rapid antigen test. If the second test which has been done by the patient is a rapid antigen and that is positive, then it doesn't go for a PCR. When it doesn't go for a PCR, I don't have that sample to retrieve from my freezer and send it for whole genome sequencing. So again, that's a big limitation. And the other thing I would like to add about the Delta variant is that there is immune escape. There is immune escape because there is a syncytium formation in the epithelial cells and the virus remains sequestered. When the virus remains sequestered in a syncytium, it is definitely going to escape the immune system and the antibodies. So that is the pathogenesis of immune escape, and that is a reason the Delta variant is able to thrive and also not be affected by the antibodies which are in circulation.
Thank you, Dr. Janti. Very illuminating. I'd like to open the questions to the rest of the floor. Anybody has any other questions to ask Dr. Janti?
Andy, do you feel ICMR should reduce its CT value cutoff of 35 to say 31 or something, or 32? Because we may be having a case demic, and that is one. And second is that the modern testing, do you think there would be some innovation so that we can pick up a variant of concern or a variant of interest when we do routine testing? That's a futuristic question.
See, Shashank, let me answer your question by saying that we are using different gene targets in PCR. Across India, you know, there is variability of the PCR kits which are being used with different gene targets. When you do that, I think it would not be prudent to reduce the CT value. We have had an expert committee meeting with the ICMR where I have participated in making the CT S35. Well, between 33 and 35, we do repeat the test. But considering the kind of kits which are being used and different gene targets, I think we can go with 35. See, what happened with the alpha variant? It was a S gene escape mutant, and that is why the thermo kit was able to detect, because it was detecting S gene. But if the mutation takes place at any other region of the virus, we will miss it in a PCR. So the only answer is whole genome sequencing has to be done on a number of positive samples. And I would like to share with all of you that we are setting up genome sequencing at Kasturba Hospital by the end of this month. And we have had generous donations from across the globe to set up this genome sequencing facility. Because Mumbai is one place where we had to send our samples to NIV Pune or to IGIB Delhi for sequencing, and we realized that we must have this facility. And since our lab is a public health reference laboratory, our authorities have taken a conscious decision of setting it up. And I think more answers will be resolved. And Shashank, it is good news for you. It's going to be at your doorstep.
Madam, can I ask a personal question?
Yes.
Okay, how much is the now rate of spread of the Delta virus in your country? Is it decreasing now?
Shashank is in the state task force. He should answer this question.
Yeah, clearly we are out of the second wave. I can take that question. We are definitely seeing a clear-cut decline. In north of India, you can clearly see that it is almost gone. Mumbai has a thick tail. Still keep reporting around 500 cases because it's rather endemic here. And in some parts of South India and some parts of East India, Northeast, the Delta strain is still prevalent. But if you see the total number of cases which had gone up to 4 lakhs per day, have almost come to 50,000-60,000 per day. In Maharashtra state also, where the cases had gone up, we are still reporting now 5,000 to 6,000 cases per day. And Mumbai city, where we live, where we are reporting almost 10,000 cases per day in April first week, has come down now to around 500 cases per day. So that's where we are. So clearly we see a decline in Delhi, where it was a very, very exponential rise. Virtually now, after doing 70,000 tests per day, is not even reporting more than 100 or 200 cases per day. So clearly the second wave is on the decline. There is no two ways about that. Having said that, we can't afford any complacency because we know that we have to be ready. And as Madam Jayanti has rightly said, we know each other for last 30 years, that we need to be ready for an immune escape, because unfortunately both the vaccines which we are using may have a challenge with immune escape. And therefore the relevance of breakthrough and reinfections becomes very pertinent. Though the cases are minuscule, we need to be mindful of that.
Dr. Shashank,
sorry.
Yes, Dr. Chaudhary.
Yeah.
Dr. Shashank, I have a question for you.
Yeah, Jamal.
So, yes, what is the CF ratio in case of second wave, that is the Delta variant cases? Do you find any difference between this earlier one and now this one? So what is the CF case fatality rate? Case fatality
rate of in say in Mumbai city and in Maharashtra of the first wave, which was there, was around 3%. And in the new wave, which was the second wave, came down to 0.5 to 1%. The only outlier has been Delhi, because Delhi had a mixture of probably an alpha and a Delta variant, and that Delhi and NCR regions showed increased CFR, and Punjab also showed an increased CFR. So except Punjab, Haryana and NCR region, where we unfortunately got a very deadly mix of alpha and Delta variant, rest of India, the case fatality rate has been lower in the second wave. So if I have to summarize, it is highly transmissible. Now we know the R naught for the Delta variant from 3.5 has gone up to 7. That is number one. Number two, it is rapidly recovering. Number three, a large proportion is asymptomatic, and that's the worry Jayanti alluded to. That doesn't build up that immune response for long-term neutralization. And the third thing is the CFR, Dr. Jamal, which you rightfully answered, is lower. So that is how we would summarize, but we are still just getting out for the second wave.
Thank you.
Excellent, sir. Excellent, sir.
Actually, there's another point which I really want to share is, of course, two things that this case which I presented, it totally defies the definition of reinfection, because this was by two different variants of concern at an interval of 19 days. The second thing, which is a total cause of concern for us in Mumbai, and we've been like across India rather, and we've been talking to a number of policy makers, is the undue importance given to binding antibodies. Presence of binding antibodies does not confer protection, and neutralizing antibodies is a RUO kit. It is a research use kit which cannot be, you can't give a report on the basis of that, but we are doing it in our own sero-survey studies. And we have done 3 sero-surveys in Mumbai, and we will be releasing the pediatric sero-survey report next week. And I would also share with Shashank, though we have been talking a lot about third wave involving the pediatric population, this pediatric sero-survey which we have conducted in Mumbai across 5,000 individuals across public and private health sector is very promising. And therefore, a large number of children are already infected. So I don't think there is an impending danger of an increased number of cases in the pediatric population. The only impending danger I can see is variants.
Dr. Jayanti, just in relation to this, actually, you know, in Bangladesh, they have seen in our COVID center that they have tested this antibody level after the immunization. Those who were actually having the infection, natural infection before, they had actually a lot of actual antibodies. There is some sort of 20-30 times more than this. So is it supportable?
See, you know HIV, right? HIV also has antibodies, but they are not protective. We have yet not established the critical value of the neutralizing antibodies which are protective. Under the circumstances, we are giving undue importance to the binding antibodies. Presence of binding antibodies, that is why the US never does antibodies after vaccination, because that means you are not even understanding that there is a T cell which has a memory cell which is going to definitely mount an immune response. So we should not give undue importance to antibodies. Presence of antibodies, yes, if it is there, fine, fair enough. If you have neutralizing antibodies, fair enough. However, that does not give you a reason to just do away with the mask. That is the reason I am extremely concerned about our students going to the US where there is a no mask policy.
Thank you, Dr. Jayanti.
Dr. Chong, just one point. Just to continue what Dr. Jayanti is saying is, we have discouraged use of antibodies, particularly the spike protein antibodies in India, which is rampantly used by labs, which give a false sense of security. See, there is only one lab in Mumbai, like the Bridge Candy, where Aruna Pujari, who Jayanti knows very well, does a virus neutralization test. But that is a research test. So, and that only will know the neutralizing capacity, or if we do a PRNT. But otherwise, in absence of that, to do those routine, see, we were doing it when plasma donation was done, the IgG. But that was also meant to do a plasma donation, which is almost out now. Because though there is maybe a value for high titer plasma in the phase, that is more or less out. All these monoclonal antibodies have come from there. So they give a false sense of security, the binding antibodies, of a so-called quote-unquote protection. And that actually leads to a challenge for a low behavior pattern, which means that people get into a risky transmissible zone. And that is what we need to mitigate across the world. It is not just a problem. It's a problem unique to everybody. And therefore, we have to be very cautious and careful. And people boast, they come with a report to me that my spike protein antibody is more than 250. and normal is 0.8, and I'm so happy, I'm protected, and they remove the mask in my clinic. And I tell them, look, this is completely wrong. It's erroneous. In fact, we have written, some of us, to the ICMR to ban this antibody in the commercial space, because it's creating a wrong, sense of security. Have a doubt as a clinician, we can send it. And that's my message to everybody, that don't get carried away. In fact, CDC guidance says that there is no need to do antibody testing. They have made
Thank you, Dr. Shashank. I think you made a very important point here. In fact, in Singapore, our Ministry of Health has strongly discouraged antibody testing. And also with, despite covering about 4 million people with vaccines, either first dose or second dose or 2 doses, we've still mandated masks in Singapore. We've told everybody not to take off their masks. So I hear your point. It's a very, very good point, and something we should not forget. Thank you very much. And Dr. Chowdhury, you have something to ask?
No, Dr. Shashank, actually, you know that our late president, Dr. K. Agarwal, actually informed us after his first vaccination, first dose, that he didn't develop these antibodies, he was telling. And so he was advised to go early second jab. I don't know whether he has taken this early second jab or not, but anyhow, that he has informed us like that. So what
Dr. Veena can add on it.
If you do not do the antibody after the second jab, suppose 14 days after the second jab, and if you do not develop antibody, is there any possibility actually that there will be no antibody titer after the second jab even? Dr. Shashank, did you hear me?
Yeah, I heard your question, and I think Naji is also here. Sir was in regular touch with many of us, and unfortunately, I think he got both his jabs, and but I think he got a variant of concern, and I think that's how we lost him. But Veena,
so we did his genome testing too. So just to solve the mystery, the case that was presented was mine. And Dr. K.K. Kabi, I got the genome testing, and it was the Delta variant. So I got the Delta variant from him because I was taking care of him. And again, to reiterate the point of being overconfident with the antibodies, I did have antibodies to the tune of about 700 after my vaccination and after my first reinfection on the 10th of April. And so I was taking care of him in the hospital and at home. And he was admitted in the COVID ward in National Heart. And though I was masked, but of course there was a false sense of security that I probably couldn't get infected again. But I did. And I somehow survived. He didn't. So yes, he got both his jabs. And before his infection, in fact, he had developed antibodies. So he was a little happy that at least some antibodies were there. But as it has been proved, it wasn't effective.
I would like to just add one important point here, since we've also, so Shashank, my lab also does the neutralizing antibody test using the GenScript assay, and we have a strip test under evaluation for the neutralizing antibodies. So this is a test which we can do in ordinary labs. It is an ELISA method. And when we have compared it with the standard, gold standard, the PRNT, we have seen that these neutralizing antibody tests by GenScript and others also detect non-neutralizing antibodies. So even with the presence of neutralizing antibody test positive, does not give you a sure shot assurance that you have protective antibodies. That is one thing which I would definitely like to share. And so even when we compare it with the PRNT, we have seen that these are non-neutralizing antibodies.
Thank you, Dr. Janti. Any other questions from the floor? Monica?
Thank you. Thank you, Dr. Shastri. That was a fantastic presentation. And thank you for bringing the case to view, because everything that was about this case defied everything that we knew, everything that the CDC was saying, everything that the infectious disease specialists knew about infection and reinfection. At the time that this infection occurred, multiple consultations with multiple infectious disease doctors at that time had said, no, reinfection is not possible. You do not develop, whether it's a interferon gamma response, whether or not you just cannot develop another infection. It was stated very clearly to me that there was no chance for reinfection. I wanted to make also a comment about antibody and antibody testing. Everybody gets the second jab and then wants antibody testing. Everybody's immune system is modulated by many different host factors, whether it be hormonal, whether it be age-related, whether it be medication-related, whether it even be time of day. There's so many variations that go into antibody level production that when you're looking at not only what is the total antibody production against the virus, you don't know, again, whether or not they're neutralizing antibodies, non-neutralizing the antibodies, whether or not those antibodies are actually protecting you against infection, but that there's variation individual to individual. So if somebody's looking for a specific number at a specific day point after their second jab, there's nothing to compare it to. You've never compared your own antibody production to another sort of infection before. So we have no numerator denominator that we can actually make a clear assessment. We have people from the US who get the jabs. They go to India, they get their antibodies tested, and then I get a phone call. How come I don't have antibodies? And my first question to them is, why did you get your antibodies tested? You got both jabs, follow social distancing protocols, and things should be okay. But this is a question that we just don't know. We don't have all the information, so we don't know where we're going. And so people have questions because they're getting the test done. So thank you for all the points that you raised today. I feel that they're very, very important and people need to understand what you said. Thank you.
Excellent, thank you. Otherwise, if we have no more questions, I just like, because last week we didn't get to do a quick update of all the various countries around us. If there are no more questions, I'll just start with a country update, whether anyone can start with his or her country. Just do a quick update.
Thank you, Dr. Chong from
yes,
South
Dr.
Africa.
Hussain, yes, please.
Thank you, Dr. Chong. In South Africa, we are facing third wave and numbers are just going. It was about 1,000 and 2,000. Now is 17,000, between 15 and 17. And we have 60 plus healthcare workers infected after Johnson & Johnson vaccine. And that happened between 2 to 3 month interval. And most of those patients were with the comorbidity. And genomic, they found mostly Delta variant. And Pfizer, at the moment, we are giving above 60 years plus age. And there are complaints of side effect, mostly after second dose. First dose, they haven't got much complaint. But thank God nobody died after second dose. And so far we have vaccinated 1.5 million. Vaccination in South Africa is still very slow because we are receiving a small amount of vaccine from Pfizer and Johnson & Johnson. We are waiting for Sputnik, which is under review at the moment. And we are following strictly now stage 3 lockdown with the curfew, night curfew, restrictions, limitation of the gathering, strict follow of SOP. And in South Africa, we are not doing any antibody test post-vaccine. Thank you, Chair.
Thank you, Dr. Hussain. Anyone wants to update me? Ravi? Yes.
Yeah.
Thank you.
Okay.
Can I?
After listening to today's discussion, in fact, the various variants of concern is a little worrying now that a reinfection is possible despite having been vaccinated. But in any case, now in Malaysia, they are worried about the variants of concern because there have been some new cases of the Delta variants. And so there's a lot of worry now here. However, we are still in a total lockdown. The last yesterday's cases reported was more than 6,000. Vaccinations are progressing, but the government is attempting to open up more vaccination centers so that more people can be vaccinated. But there's also a concern of a shortage of vaccines coming into the country. At the moment, there are only two types of vaccines that are being used in Malaysia. Number one is the Pfizer. Number two is Sinovac. They had some from AZ, AstraZeneca, but that was a limited number, and that has been given to those who applied for it, because there was so much of concern with the AZ vaccine that people were a bit worried. So what they did, they put it up in the website and said those who are interested can apply. But somehow or other, it got snapped up immediately. So the concern now here is the variants of concern is actually the biggest concern in this country now. And I hope and wish that all of us throughout the world will come out of this this dilemma and this pandemic. Thank you.
Dr. Chong, Dr.
Yes,
Chong, I have to leave.
Yes.
So I want to just before informing you the situation here, I just have a question to everybody, actually, whether you have got any information regarding the interval between the two vaccines, actually, which is permissible now stands. Because in our country, actually, you know, near about, this is 1.5 million people. They were given the first jab only, and there is shortage of second jab. So we are just finding out, trying to get it from the USA, and probably it will come within 2 to 3 weeks. Probably, I'm not sure. Actually, that's an assurance only. So, do you have anybody is having any information that what is the interval actually? Highest interval can be permissible in this case of AstraZeneca vaccine?
Dr. Shashank?
Kamal, two things. When there was no variant of concern, with single shot of AstraZeneca vaccine, you were getting 76% protection, and you could defer the vaccination for 3 months. However, with the Delta variant, we know that with a single jab, the protection may only be 25 to 30%. So therefore now the UK, Public Health England and Public Health Scotland have revised the duration. And they have said that now you should give the 2 shots of AstraZeneca within 4 to 8 weeks. So initially they said 8 to 12 weeks. They deferred their vaccination by 3 months. But subsequently, when the Delta variant and the Delta Plus broke out in Public Health England and Public Health Scotland, both of which have published data, they have actually truncated it. But if you don't have anything available, then you keep the dose a little late because you would have vaccine availability. So do not mix the science of the duration of vaccination with the availability and public policy. So obviously, from a science standpoint, the current data suggests that the second dose should be given within 6 to 8 weeks. And that is what has 6 to 8 weeks. 8 weeks. I can put out those papers out from Public Health England and Public Health Scotland because of the Delta variant, which is now likely to be the omnipresent variant across the world, at least in 40 to 80 geographies now. 40 geographies are confirmed, other 40 are presumed.
Yes.
Thank you, Dr. Shashank. Thank you so much.
Now you want to update us on Bangladesh? Yes.
Yeah, just because I was just informing you formally before the meeting. Actually, now formally just informing you that actually we are in the second wave now, and it's not in the capital city much, but in other districts actually close with the border area with India. So we are very concerned actually now. I'm not sure whether the capital also will be involved soon. So regarding the vaccination, that's actually we are in short of vaccines, and we're trying to procure it, and we are hoping that from the next month it will be enrolled again. So it's very slow now, we can say, and thank you so much. This is the situation.
Thank you, Jamal. Is there anyone that can update me about India?
I can do a very quick update.
Yes, please.
India was now the total number of cases from India, daily cases, is down to 60,000 from somewhere around 90,000 just probably 10 days back.
Yes.
What was actually concerning Indian figures were the high number of death rates. You know that always deaths lag after the wave is declining. So just last week, we had around an average of 3,000 to 4,000 deaths being reported every day. A lot of that was reconciliation deaths because a lot of people, when the healthcare infrastructure is overwhelmed, they don't report the deaths in the system or upload it. So most of the people, as the wave receded, they uploaded it. So we suddenly saw 4,000, 5,000 deaths. Now the deaths have come. I'm happy to report in the last 3 days, around 1,300, 1,400 deaths. So India is now reporting daily cases 60,000, daily deaths approximately anywhere between 1,300 to 1,400 deaths. Clear-cut decline being seen from across geographies. Very, very good and impressive decline in Delhi, NCR region and north of India. A reasonable decline seen in Gujarat, Madhya Pradesh and Karnataka. Still a thick tail seen in Mumbai and Maharashtra, still reporting around 6,000 cases. The disease is still very much there in Andhra Pradesh, Telangana, Tamil Nadu, Bengal, and northeast of India. We call them as the states of concern. So they still remain to be the states of concern.
Thank you, Shashank. Anyone can update me on Pakistan? Is anybody still around? If not, Dr. Bukhari?
Okay.
Everybody is muted.
No, his connection is not.
Bukhari is muted, I think.
Yeah. Oh, his connection is not so good.
Okay.
Dr. Bukhari, I will close your camera so that your voice is audible.
Okay.
Yeah.
Okay. Now you are hearing me?
Yeah.
Okay. Regarding Pakistan, the third wave is almost our daily cases. Today, I think it is less than 1,900. Our no delta variants are 19% cases were sequenced at National Institute for Science. Number we are looking almost 117 that is called the but we still asking the people to go for the vaccine. Alhamdulillah, there are a lot of vaccines. 5 vaccines are there. We have started the further vaccine. Government is supplying freely to people who are more vulnerable, people who are educating the AstraZeneca, females who are under
I think we have a bad connection for him.
Yeah.
So we are now ending our third wave, but we are asking the people that they must apply, they must follow the SOPs because still we are in the pandemic and the virus is around it. Hopefully, like other countries in Pakistan, we will also control. We are opening the schools, colleges, universities, and exams. And we are taking strict measure in the SOPs in our academic areas and the institutes. And still we have 2 days, Saturday.
I think we've lost Dr. Bukhari.
Yeah.
Okay, I'll just quickly update everyone on what's happening in Singapore. So we have, due to our genomic analysis, we have discovered 550 cases of Delta variant in Singapore. All right. 122 of them were imported. That means they came on a plane. But 400 plus were, the rest of the 400 plus were community cases. And so our outbreak, our mini outbreak here is very, very small compared to elsewhere. But I think yesterday we had 20 cases. Most of them were in quarantine. About 3 or 4 were unlinked. That means de novo. We couldn't figure out where they came from, or we're trying to link them up. But right now we're starting to reopen the economy a little bit again from the mini lockdown of the 6 weeks. So that's where we are in Singapore. But we're doing a lot of genomic analysis here to figure out the variants of concern. So right now it's 550 Delta variants that we found in Singapore. And our government, as I've told you, we continue rolling out our vaccination program. About 4 million out of 5.5 million people have already been vaccinated, at least 1 dose. 2 million, 2 doses. So that's where we are at this point in time. Thank you very much, Dr. Janti. It was a brilliant discussion and very good presentation, and Dr. Shashank for contributing to that. The bits here and there, which are very, very, very important. And some of the messages today are very, very important. In particular, the bit about the antibody testing.
Yes.
And the fact that we still need to wear our masks despite being vaccinated. And of course, the importance of host factors, viral load, and variants of concern. So I think that's the take-home message for today, these few points.
Can we, Dr. Chong, can we have Dr. Veena? I suppose she needs to say something over here.
Yes, please, Dr. Veena, please say something. Thank you.
You're mute.
So yes, I would like to thank Dr. Jayanti for a very useful and illuminating talk and presenting my unique case. Your presentation has reinforced what I always knew about you since we were in the pre-med together in 1975, that there is no substitute for hard work and commitment to achieve excellence, as you have proven and was also exemplified by Dr. KK. Dr. Shastri has stayed on alone in Mumbai for the love and dedication to her work, while her entire family is in the US, and her husband also, who has relocated there last year for professional reasons. Thank you once again, Dr. Shastri, for sacrificing your well-deserved Sunday morning for us. And I'd like to thank each of you who are carrying on the legacy of Dr. KK on this platform. Thank you so much.
Thank you. Thank you, Dr. Veena. So, Dr. Chong, I think we can close the session today. We are well on time today.
I think Dr. Shashank wanted to say something. Dr. Shashank? No. Okay.
Okay.
I just want to thank all of you for this, for number one, the opportunity, Veena, to present in this wonderful platform. And this exchange of information was so useful. I have only one question to ask Dr. Chong. So all the people who come from outside, I mean, whoever lands at the Singapore airport or through surface transport, are you necessarily quarantining them?
Oh, yes. First of all, I'm sorry to explain that we've kind of stopped people coming from the subcontinent, for various reasons. But yes, everybody who comes in through Singapore airport will be quarantined for 21 days, irrespective, And yeah, so that's what we're doing. And on top of that, we have very, very good contact tracing. Almost the whole population is using an app, which I think I've showed you in the past on our handphones. And the app is quite good. It's able to really ring fence. So we've been able to use the app and all the data that's been collected from the app to straight away ring fence the first, initial contacts of that particular case and so on. And then, so we've now got about 8,000 people in quarantine because of the contact tracing. So that's been relentless and that's been really, really helpful. We've kind of coming to live with the virus. We have to live with it because we're a small place and we don't have a hinterland. So we have to live with it. We are contact tracing. We're swabbing entire populations of a particular area or a block whenever there's an outbreak. So we're doing quite aggressive kind of measures, public health measures to try to get it under control. And genomic sequencing is very important.
Dr. Chong, how much manual entry is required in this app and how much it is automatic?
Actually, we have a sensor now at the entrance of every mall, facility, clinic, whatever building. And all you do is you switch on the app and you tap your phone. Or you tap your token against a sensor. There's a sensor. So it's very easy. You just, as on your way in, they take your temperature with a camera, the thermal camera, and then you just beep your phone. You just beep your phone and then you walk into the building.
So it really doesn't depend on like somebody entering manually that is it well, is he not well? That's what's happening. Okay.
No, not at all. So you just beep and then later on when they figure out whether you're sick or whatever, then they'll come look for you.
Oh, we have somebody from WMA today. Let me see if she's joining in. That's good.
Oh,
we in
Hi.
Malaysia have the same app, Dr. Chong. We use this, we call it the My Sejahtera app, where every mall, every premise you enter, you have to scan the code. And then that is captured. And if there was an incident in that area, they will be able to trace all those who were exposed in that particular area. Very effective.
Yep. That's right. I think technology is the way to go. This is my app, and it even shows my vaccination status and so on. So everything is there. So it's quite useful. Yeah.
Do we have Dr. Heidi here?
Hello, Dr. Heidi is here.
Hi. Welcome to CMAAO meeting.
Thank you.
I think this session is pretty lucky we have her here.
Yes, I'm at the Karolinska University Hospital, but it's been a very busy time still because of the pandemic, and most of the sessions I have missed out or I've been very late in. But I'm very happy to be able to hear a little bit.
So can we have some update from you since you have joined this meeting? Yeah, we would love to hear from you.
Yeah, what's happening in Helsinki?
In Stockholm?
Oh, sorry, Stockholm. Sorry.
Yes. So the situation here has calmed down. We have now a sharp drop in the inpatient care after wave 3. So this, so I'm in the leadership of the university hospital, and we've had a sharp drop in the inpatient care and ICU. We have now vaccinated half of the population with at least one shot, and we are working on. We do have a spread of the Delta variant of the virus here, and it's actually spreading quite rapidly, unfortunately. So we are concerned that this is not under control here, despite vaccination. So we do also have reinfections, like you have talked about here, what we see in the population. And we have prolonged the restrictions. We were to step down the restrictions quite rapidly during summer, but they are withheld partially until September at least, a little bit like the UK, where they step up again in the restrictions. We do open the borders though, but it's required to have vaccination certificate, and that will be in place July 1st. So you might travel, but it's complicated. And most of the European countries require us to have a PCR test or a negative antigen tests, or approve of full vaccination, at least 2 shots of any of the vaccines. So it is, they are opening up, but not as we had hoped for, because we do have a spread of the virus, and it's definitely not under control. So, but in the healthcare situation, what we see now is a post-COVID problem. Many have long-term affections, problems. The population is fairly young that are affected, and they don't need to be hospitalized, but they are partially not able to work. So we see long-time effects. So we have started a post-COVID ambulatory unit in my unit in the Karolinska University Hospital, and we are starting now to receive patients. And there we have a team, a multi-professional team built up with physiotherapists, psychologists, lung specialists, infectious specialists, of course, cardiologists, because we do see a group of POTS, the cardio rhythmic problems. And we also have connected to us rehabilitations, because we see a neuromotor and fatigue problems. So it's very multi-professional. And this group is estimated not as big as the estimations from the UK, but still significant So that's our focus at the moment in my unit. Oh, that was a short update from Stockholm. I've been living in the hospital, I feel like, for a year now.
Thank you, Heidi, for being here. And for our viewers, she's from Swedish Medical Association and president-elect for World Medical Association. She's also the chair for Medical Ethics Committee. Welcome on board. And this is not the first meeting. I would say please continue joining the meeting. Your valuable inputs are required for these meetings. And thank you for joining.
Thank you.
Thank you.
Anyone else has questions here, or? Okay, so this is the end for the meeting. We are 63rd meeting successful for a wonderful topic. Thanks to Dr. Jayanti for being with us and enlightening us for the valuable topic. Thank you all of the medical association for joining us, and special thank to Dr. Veena and Dr. Heidi. We will close this session. See you next week. The topic of the next week will be announced shortly.